Welcome back to From the Clinic to the Living Room. Again, I'm your host, Melissa Wilson. I have two very special guests that help write this wonderful document that is the Stage 4 Treatment Option Guide that is available on AIM at Melanoma's website. We can post some links for how you get this document. It is absolutely amazing. Dr. Anna Pavlick, she is a physician at the Weill Cornell College in New York, and Dr. Michael Postow. He is also works in the Melanoma Center there at Memorial Sloan Kettering, also in New York. So the two of you, welcome so much to our webinar tonight. Hopefully we will get lots and lots of questions for the two of you to answer, both about the document and in general about stage 4 disease. Thank you so much for coming.
Thank you for having us.
Yeah, my pleasure.
This is my first two-person webinar, so you'll have to excuse the excitement that's going to ensue for the next 30 minutes. But so I guess I just wanted to first introduce the document. So the two of you have been working on this. It's a beautiful, this is in black and white, obviously, because I don't own a color printer, but it's a wonderful document that just kind of talks about all the things that a stage 4 patient with melanoma needs to know and things that they can go in with their doctor to ask and talk about. And there's prompts in here. So I wanted to just kind of start it off with, what made the two of you decide that this was a document that needed to be made?
Okay, I'll start.
You're first. Go ahead.
Okay. I think it was something that actually, the folks at AIM came to us and said, as two melanoma oncologists, can we have a sit down and talk about what do patients need to know? What do family members need to know? What are some of the really important questions that you get from patients when they come into your office? Because wouldn't it be a great idea to just put all those thoughts and questions and guidelines into a document so that when someone gets diagnosed, here it is right at your fingertips, take it to your doctor, ask these questions. And, Mike and I worked with the folks at AIM and really, it was an incredible amount of work really on AIM's part. And I'm so proud to be part of this document because I think it really is such a great guide to what you need to know when you get diagnosed with stage 4 disease.
Yeah, I mean, it's comprehensive all the way from what do you need to know now, what is stage 4 disease, to these are the types of scans, to here are all of the treatment options and their common side effects. So definitely check this out. I wanted to kind of start talking to the two of you about, what an overview of the treatment options. What is standard of care for stage 4 melanoma now?
So I think I'll take that because Anna started with the other discussion. So the first thing I'll say, and it was a pleasure to be part of this project with AIM as well, because I think that one of the items that I talk about when I'm meeting patients who have a new diagnosis of stage 4 melanoma is I explain there's a lot that's out there on the internet. Some of it's great, some of it's bad, some of it's totally incorrect. And so I wanted to take an opportunity here to say, well, let's put something together that is accurate and does reflect current understanding. And it was a pleasure to put this together with AIM and with Dr. Pavlick as well. So when I see a patient with stage 4 melanoma, I think the first thing that is on most of everybody's head is this number stage 4. What does that even mean? And I think very simply, and I really believe this, and I feel that an important thing to mention here is that stage 4 exclusively just means the melanoma went from somewhere in the body to somewhere else inside the body. That's all that it means. It can just be a tiny little spot and people feel entirely well and they're going to do incredibly well with that diagnosis. It just means something from most likely the skin, where the melanoma usually starts, just spread inside the body somewhere, and that we need to talk about different treatment to try to help inside the body rather than, just kind of doing more surgery on the skin or lymph nodes like some people may have had before. So I think getting an understanding of stage 4 means it just moved from one place to the other, and that usually that means we have to do treatment inside the body. And then when we think about what are the treatments that are going inside the body that are important, there's really kind of two main initial treatments that we like to start with to think about. One being immune therapy. And immune therapy is a way that we boost our own body's natural immune responses so that we can use our own immune response, which fights off bacteria and fights off viruses, but it can actually also fight off melanoma. And sometimes it just needs that extra little kick to kick in and fight off the melanoma. So the treatments for stage 4 are usually some form of immune therapy, or in certain situations, if patients have what's called a BRAF mutation, and I know we can talk a little bit more about that, sometimes patients with the BRAF melanoma will take pills that target the pathway that's activated when the BRAF mutation is present. So those are the kind of initial things to think about when confronting a new diagnosis of stage 4 melanoma.
And you make a extremely good point. You know, a lot of our patients get very held up on the semantics of I have stage 4 disease, and they look at it and think that that is the worst possible thing that can happen. And you're right. It's really just a definition of this is where your melanoma has gone, especially with the things that we have available for treatment now. So, now you talked a little bit about the targeted therapy and immunotherapy, which kind of leads into and having the BRAF mutation. So that leads us into, for stage 4 patients, really what testing should be performed before we're looking at what treatment we're going to do. Anna, you want to take that one?
Sure. Well, I think obviously for people to know that they have stage 4 disease, they've already undergone imaging.
Right.
So, excuse me. What is the standard imaging that patients undergo is an MRI of the brain. And again, patients will ask us, well, why do you have to separately image the brain if I'm getting a PET scan? Because
Correct.
Isn't the PET scan scanning me from the top of my head to the bottom of my feet? And the answer is yes. However, the brain utilizes a lot of sugar. And so looking accurately at the brain requires that we do an MRI because it's very specific and can pick up really tiny things that may not normally be seen. So patients will either get a PET CT and a brain MRI, or get an MRI with CAT scans. All are acceptable. And that's how we identify that the disease has now gone to a different body part or an internal organ. With that being said, patients then have a biopsy to confirm that, yes, this is the melanoma that has returned. And then that tissue gets sent to the pathologist to then extract the DNA and run what we call genetic sequencing.
Sure.
And so that sequencing is looking at the targets that tumors may have, that we have drugs that can target those mutations and control the melanoma. It just provides us with what are the treatment options available for that patient. Doesn't necessarily mean that we're going to utilize that information right from the get-go. As Mike said, sometimes even if you have a BRAF mutation, we may opt to start with immunotherapy first, but we like to have that information at hand so we can have the discussion.
Correct. And it does take some time to get those tests back. And so we always tell patients, we may not use this information right now, but we want to have it so that if and when we need it, we're not scrambling around waiting for, the couple of days or weeks that it takes to get back. So, I think that's something that is important. And, patients also get I get a lot of questions on, different platforms of, what if I can't get a PET CT? What if that isn't something that's approved by my insurance? Is a CT scan good enough? And, we always try to reassure our patients that yes, in fact, CT scans are extremely good at diagnosing stage 4 disease. And, sometimes we get the question of well, if I had a PET to start, shouldn't I have a PET every single time? What are the two of your thoughts about that?
I personally don't have a strong preference, CT versus PET. Sometimes the surgeons that may be part of a patient's care before the patient comes to me, they'll order a PET scan or a CT, and I don't feel I have to repeat the other imaging modality if they had one versus the other.
Sure.
there are some things that are better about CTs. Everyone thinks PETs are better because they're more expensive and insurance doesn't cover them. And then that makes people want to feel that there's something better about, why is their insurance not covering? I'm going to fight the insurance. I'm going to get this PET because I want a PET. I think a CT is more than sufficient. If anything, CTs are better at looking inside the lung.
Right.
Small little areas on a PET scan, that especially things that are less than a centimeter in size, often don't show up very well on a PET scan. So I will give reassurance to getting a CT scan. There's some different considerations. If someone has some kidney problems, sometimes a CT with contrast can be problematic. And if people have diabetes, sometimes it's hard to get a PET scan if the sugars are too high with the way that the scans work. I don't think that you have to always get the same imaging modality if you start with something at baseline on treatment. Although sometimes there is advantage in comparing apples to apples. So if you see some abnormalities on a CT at baseline, I kind of like to get another CT just so I'm comparing CT to CT. Sometimes you can get a little confused if you have a CT and then you get a PET scan later, or, I think there's a little bit of a kind of, I like to keep a little consistency with whatever was done before, but I don't have a strong preference about what to start with in the beginning.
And then there was a question, which I only want to handle this now just because it fits into what we're talking about. But there was a question from Facebook that is, at what point do you recommend stop getting scans? So like, let's say in the best case scenario, your disease goes away after treatment and you're a complete response and, we're scanning after treatment is completed. At what point do you feel like you can stop getting scans? I think that's a tough question to kind of pin down, really. It's so individualized, but.
Yeah, but I think it's a great question that we can actually ask that question. When do you stop scanning after you treat a patient with stage 4 disease who no longer has disease?
I know, we couldn't have talked about that 10 years ago.
20 years ago, when I started doing this, not so long ago for Mike, not 20 years anyway, we didn't have that discussion. It wasn't a question.
Right.
So look at how far we've come that we can now say, well, when do I need to stop getting scans? I don't think most of us really know. I think many times it is an individual decision based on the extent of someone's disease, how quickly their disease went away with respect to after they got treated. Did their disease go away quickly? Did it not go away quickly? Did you have to, monitor them longer? I think minimum 5 years is kind of my threshold.
Sure.
Anything after that, I tell patients we play let's make a deal. When are we gonna scan you and how often? And the answer is we don't really know.
Yeah, you should be in one of my clinics where, they're to that point where they're like, well, I could just get scans once a year. I'm like, yeah, but I just really feel more comfortable with just staying at 6 months forever, as long as your insurance will cover it. That's a long time to go. So I think, hopefully in the future, we'll be able to answer that question with actual clinical trial data to be able to say.
And the longer patients stay well, and we know how that their responses are durable, again, then you have to start weighing out risks of not scanning versus risks of radiating, because every time you get a CAT scan, you get radiated.
Yep.
So again, another good problem for us to have.
Right. I want to kind of move on just a little tiny bit because we're getting some questions and I know that that's only going to, double in the next couple of minutes. But so what do we do, I guess, in this case, if standard of care drugs, well, let's back up one step. What do we do to decide what we start with? I think, unfortunately, this is a little bit complicated and I don't think that there's a, do A, then B, then C, then D next. And not every decision is right for everyone. So I just wanted to give the two of you the opportunity to kind of, because a lot of times patients don't get to hear the thought process behind why do we make the decisions that we do in a clinical setting, from targeted therapy versus immunotherapy versus injectable therapy. How do we make those types of decisions? I think it's helpful to hear that out loud.
Sure, I'll take you through the little algorithm I run in my head when I'm seeing a patient with stage 4. And it's first question is kind of coming up, do I know the BRAF status or do I not know the BRAF status? And many times you don't know the BRAF status because you have a stage 4 diagnosis and you make plans to test for the BRAF mutation, but you don't have that in your hand at the time you're making initial treatment decisions. So the decision really, for the most part in my practice, outside of clinical trials, that's a whole separate issue, and we can talk about that maybe later. But with standard of care, it's either a single agent PD-1 drug, which would be nivolumab or pembrolizumab, and I say that they're even more similar than Coke and Pepsi. I can't tell the difference between Coke and Pepsi. Some people can, but in terms of all the data that's out there for nivolumab or pembrolizumab, they're basically the same. So those are that's kind of the single agent PD-1 approach, or then it would be PD-1 in combination with another immune therapy drug called ipilimumab. And so trying to decide if someone should get PD-1 alone or the combination of PD-1 plus ipilimumab is the kind of decision there. And there are a lot of different factors that go into that, where the melanoma is, if the patient's feeling sick with the melanoma, and kind of what the other medical comorbidities or other medical issues that a patient might be working on and handling. And kind of we'd make a joint decision on which might be the more appropriate approach there. After starting with immune therapy, if that doesn't get us to where we want to be, then that's where, in my practice, the BRAF mutation comes into play. If a patient has a BRAF mutation, then often I'll give the BRAF drugs as a subsequent approach. And then, that's the kind of the second treatment that I would consider in some of those patients. And with the immune therapies, if I've started with the single PD-1 drug, then I usually give the combination of immune therapy drugs, the ipilimumab and PD-1 subsequently. So that's, I think, kind of a broad overview. There's a lot of subtleties. We're always trying to find clinical trials and new agents. And any place along the spectrum of this, clinical trials can be appropriate. But I think standard of care, that would be my general answer for that.
Okay. And I think, before I let Anna have a chance to, answer as well, if she wants, I just, we have a lot of patients that come in and sometimes we do decide to start with a clinical trial. And so, I think that it's important to reiterate to patients that, sometimes that's the right thing to do. Sometimes clinical trials are only available first line and they have great data. Sometimes there are other, factors that play in terms of injectable disease and things that make clinical trials sometimes the right choice. Because I know a lot of patients get the misconception that, oh, I'm on a clinical trial, there's nothing that they can do for me, whether it be first line or second line or third line. So, Anna, if you want to speak to that as well when you.
Sure. And I think that's so important that clinical trials are not viewed as experiments. They should be viewed as opportunities, because many times clinical trials will take what we know works and add something to it. I mean, we haven't gotten where we are in 20 years by not putting people on clinical trials. I mean, this is how we made our advances. People knew that 20 years ago, chemotherapy just didn't work. So everybody came, to big centers like Memorial, like Cornell, and said, I have melanoma. I want to go on a clinical trial. What do you have for me? And it's because of all of those patients who said, what we have is not good enough, that we've been able to make these advances. And so I know that when I talk to my patients, I always talk to them about these are what the standard options are. But if I have a clinical trial that's building upon what our standard options are, and I think, this is an opportunity to get a drug that may not be made available to us until FDA approval, I'm going to present it to the patient right up front and say, yeah, but I've got this study, and I think that this has the potential to be our next step forward, and build on the success that we've had. So I think you need to think about it, and then we go from there. Whether it's first line, second line, third line, good drugs come about because people participate in clinical trials and are not happy with the status quo, and that's how we have to look at it.
Yep. And I think too, it moves it moves the disease and the treatment for the disease forward, especially in instances where you have refractory cases where, patients have had some standard of care drugs. We need to know what is the next step, where do we go from here? And I think, in looking at the clinical trial medicine that's available right now, that's where a lot of the focus is on for PD-1 refractory and what happens when you do become resistant to BRAF/MEK inhibitors. Where do we go from here? So I think, that advice of looking at it as an opportunity is by far the best way I've ever heard a standard of a clinical trial described. So I think that's phenomenal. The other thing that patients seem to be extremely concerned about outside of, their disease progressing and needing to participate in clinical trials are, what kind of financial assistance is available? And I know, in clinical trial medicine, a lot of times drugs that are new and are, being tested are covered under the guise, under the trial, and things that are standard of care tend to be billed as standard of care. But one thing that I just wanted to point out, because it does talk about this actually in the guide, there's a whole section on, applying for grants, and each of the standard of care drugs actually have assistance programs that are very generous. They provide grant from donors, and all you need to do is apply. And so a lot of times we'll get questions from patients that are at like small community centers that may not have access to a social worker like we do at our big academic centers. And so this guide actually gives a really great page of, how do I contact drug companies to help with financial assistance? How do I contact other grant assessments and things like that. So you both don't need to speak on that. If you want to, absolutely. But I just wanted to take the time, like I said, to point out that there is some information in here about financial assistance and there are grants available. So please ask. If you don't have a social worker at your center, please, feel free to contact AIM or contact myself, and I'd be happy to help you find that. So if you want to add anything, that's okay. But I just wanted to take that opportunity to kind of soapbox some of that.
No, I think it's important that patients ask about this. And I think as doctors, it's on us to also mention that we understand that doing all this is, incurs financial challenges for most of our patients in one way or the other, whether it's missing work, it's bringing a loved one to treatment or other things. So I think attention on this issue is a really important one. And I think everyone should just get it out in the open, and we can try to work to best possible solutions, because there are these opportunities out there that should be taken advantage of.
Yeah, exactly. And to just inform patients that, there are ways, and all we have to do is try. So, don't be discouraged. Anna, did you have anything that you wanted to add?
No, I agree. These are just such great avenues for patients to get access to the meds that they need. And again, I think sometimes we as doctors forget to ask that. We just assume everybody's got great coverage. But even if you have coverage, sometimes there are very large copays that come with the medicines that we order. And these are opportunities, again, and avenues that patients need to ask us about, because there are these grants that are out there that will help cover copays. So patients don't have to lay out a truckload of money every month to get the life-saving medicine they need.
So I think I'm going to try to cover some of the questions because we're getting close to our 30 minutes. And I just want to make sure that we get some of the, questions answered from the viewers. I do want to point out that some of these questions that are getting are extremely good, but they're very personal. So I will go through and kind of type if something, to the viewers, if there is something that we really can't handle live, but there are some really good questions in the question and answer box. So I want to try to get to those. Jerome asks, do you ever recommend radiotherapy alongside immunotherapy? Would there be a scenario where that would be beneficial to a patient?
I think the short answer is yes, absolutely. We often have to do radiation along with immune therapy. And so immune therapy is treatment that goes through the whole body. It's intravenously administered and the drugs go through the whole body. However, sometimes a certain specific area of melanoma needs kind of an extra boost or extra attention, whether it be a spot of melanoma in the brain, whether it be a spot of melanoma inside the body that might be at risk of some kind of issue. And that's where radiation can really come in to help. And so I think it's important to think about whether radiation could be beneficial. I haven't seen it where you end up radiating everything, but if there's kind of a local problem, then that's where radiation can be, almost to think of it as like the icing on the cake. The immune therapy is the important kind of bread and butter that needs to get going through the whole body, but then one could think about a selective use of radiation in a certain area, or if everything is doing well with the immune therapy, but there's one area that's just really not behaving like we want it to, that's where radiation can be specifically helpful as well.
Okay, that's great. One of the other folks from Facebook had actually asked about CTDNA. And I know that, we've been looking at this as an option for monitoring responses and pseudoprogression and things like that. And so the specific question that Ed asks is the use of CTDNA. Do you use this blood test? And if so, what, situations or scenarios is this being used? Is there research behind it that says that this is something that in melanoma specifically that it can be helpful?
Okay, my turn. It looks to be a very promising technique that we're using. Many times it is very expensive. It has to be sent out. A lot of times we offer it to patients when they participate in clinical trials. It's one of those adjunctive correlative markers that we follow that helps validate whether that this is something that is helpful or not. At least for me, it's not anything that we do routinely at this point, but sometimes it can be helpful. I don't know about if Mike has any other experiences.
I think it is a promising, cool technology. And to be clear for everybody, when we talk about CTDNA, what we're referring to is circulating tumor DNA, meaning a blood test that looks at the genetic material that's floating around that reflects shedding of that DNA from the tumor cells, so that it's a way to, people call it a liquid biopsy. You may have heard of it that at some time. So I think it has a lot of promise in melanoma, both for potentially ultimately detecting recurrence earlier in the blood versus CT scans and helping monitor patients on drugs like immune therapy approaches. But I don't think anything is yet to the point where this needs to be a standard part of melanoma care in 2022. I hope that will change with the promise that we have. The one thing I would just call to attention is that sometimes in situations where a biopsy is not feasible or cannot be done, there are some different platforms where you can do circulating tumor DNA and try to see if you can find out about a BRAF mutation in those situations. It's not ideal. It's better to test for BRAF mutations on a biopsy specimen. But in rare cases where you can't do a biopsy for some reason, there are some platforms and there may be a role for circulating tumor DNA in that specific area. But that's a real nuanced issue that's very infrequently encountered.
Yeah, I know. I feel like our clinic who, doesn't really come in a scenario where we don't have tissue somewhere, whether it was the primary or a lymph node or some accessible disease that we can gather. But it is a very useful tool if there is a scenario where someone presents with stage 4 disease that for some reason can't be repeatedly biopsied, to get the BRAF mutation. One of the other patient, there's so many questions. I'm sorry, I'm trying to read through all of these, but one of them asked a very good question. What do you think about immunotherapy for someone who has been diagnosed with sarcoidosis or in general, another autoimmune process?
My turn? Okay. I am not a believer that if you have an underlying autoimmune disease that you are not a candidate for immunotherapy. Mm-hmm. I think we need to have discussions with patients regarding what the immunotherapy may do to the underlying autoimmune disease. Sometimes the immunotherapy can cause the underlying disease to flare, whether it be sarcoid, rheumatoid arthritis. But in general, my experience has been that patients tolerate it just as well as anybody else.
Yeah.
You may need to tweak some underlying meds, to control the underlying disease, but it's not a no, you can't have immunotherapy because you've got this going on.
Mm-hmm.
And I think that's important because when we did our clinical trials, we didn't know what was going to happen. And so patients with underlying autoimmune diseases were excluded from the trials. So it's a great question, and very important that people know that just because you've got another medical issue, that you are not excluded from, this life-saving therapy.
Correct. Yeah. And we always try to point out to our patients as well, this is a team effort. So, we get their rheumatologists involved or get their gastroenterologists involved and say, look, we're planning on treating so-and-so. They have a history of ulcerative colitis. We just need to be on alert and be a team and manage this together. So I think the better the communication is between the different disciplines, I think patients have done really well. We haven't had any issues on our end as well. Mike, did you have anything to add?
No, I would completely agree and say that patients with autoimmune diseases can benefit just as well as people without autoimmune diseases, benefit against the melanoma. So absolutely should be getting these drugs and kind of work in a multidisciplinary way, but we just need more studies to be done so we really know kind of the risks and things. But I think these patients should be offered them without question.
Good. And then so that in the event that this doesn't, our webinar doesn't get too long, I just wanted to kind of end with this question because I think it was extremely good. It came also from Facebook. Are we to the point where we can say that stage 4 melanoma is curable?
I'm muted. Being the longest practicing melanoma oncologist on this call, I am actually going to put my nickel down and say yes. I'm so excited to be able to say that. I used to tell patients, I'll tell you you're cured when I retire. So when it comes back, you can't blame me. But I think with the durability that we see with so many of our therapies, and we know that we've now been able to follow patients who are on clinical trials now 6 years, 7 years out, and those responses are durable and those patients are well. I think we're getting a little bit more comfortable with saying, yeah, I think we're curing melanoma.
That's amazing. How about us newer bees, Mike? What do you think?
Yeah, I mean, I agree. And Anna has me on that. So but I didn't start yesterday either. And I've seen a lot of patients over the time I've been doing this. And it's a wonderful thing to have people coming back really either every 6 months or every year, good scans. And again, going back to the question we were talking about earlier, I don't even know if I need to be doing these scans anymore, but it's nice to hear the social updates and updates about grandkids and updates about weddings and all these kind of fun things. And people will say, is this patient cured or not? The truth is, I don't know that we really know, but it's really nice to believe that the answer is yes. So why not?
Yeah, I'm with you, Anna. I'm definitely glass half full in the time that I've spent.
Yeah. Sure. And honestly, I've looked at some of the names that are on this chat of our participants, and I can honestly tell you that there are some of my patients here that are cured. They haven't seen me in a while, because they've relocated, they've moved because of family, because of grandchildren. And it's just so awesome when every once in a while their name will pop up or, get a card saying, guess what? I'm a grandma. Guess what? My daughter's getting married. Guess what? I just adopted a new dog. I mean, it's just so nice to watch people move through a normal, healthy life and be part of that.
I 100% agree. And I know, we can't fix everyone. This doesn't happen for every single patient, but the proportions of patients with stage 4 disease that are here years and years later is just climbing and climbing. So there's so much hope moving forward for melanoma and other solid tumors, but especially for melanoma. So
the other thing I just want to add Yeah, I just want to add to that too, and say you don't have to have a scan that shows no melanoma to be in that category.
True.
So I have a lot of patients who have a little spot, a ditzel, a doodad, a little schmutz here, a little schmutz there. Whether that's melanoma or not, who really knows? But it doesn't matter because people are living healthy and feeling well. And I think I will just reiterate, it's not so much what we see on scans, it's how you're living your life and how you're feeling. It's much more important. And people can live with stage 4 melanoma that you see a little spot or two on a scan, but no one would ever know it. No one would ever think about it. And so I think, that just kind of free yourself a little bit of the details on some of that. That's how you can also beat it and feel good about what's going on.
Beautiful. I like to end my webinars like this with such positive, happy thoughts. So I just wanted to thank again, both of you for coming on and sorry for all the, do you want to go? Do you want to go? But this is my first time I had 2 guests. So I appreciate the patience with that. This is the stage 4 guide. It's available. You can download it and print it off of AIM's website. This is an amazing document. The 2 of you have done a beautiful job with this with AIM, and it's just great. And so I appreciate all of your help and thank you for joining me tonight. If there's anything else that you'd like to add before we go, please feel free.
No, I just want to thank you for having us, and I want to thank AIM for allowing Mike and I to work on this really beautiful document. I just like to tell patients, every patient has the right to believe that they're a survivor until proven otherwise. So that's my departing word is everybody's a survivor. Let's go for it.
I love it. I love it. Well, I hope you guys all have a good night. And I guess we'll see you next time. Have a wonderful evening. Thank you again for both of you for coming and sharing the night with me.
Bye. Thank you very much.
Thank you. Bye-bye.
Bye.